Hello, and welcome to Lullabies Liberation, Empowering the Black Experience in Healthcare, a podcast presented by Doula Community Alliance. I'm Mai Heath, naturopathic doctor, birth worker, childbirth educator, and executive director of Doula. This podcast is intended to get information out to our community, to reach more people, and also be a platform for those in the community to share their experiences, thoughts, and insights on topics to do with healthcare and well-being. The statements and point of views and perspectives are unique to each individual guest and are not necessarily representative of Doula Community Alliance. I'm joined by my co-host and media veteran, Miss Natalie Battles. Welcome, Natalie. Happy to have you here today.
I'm happy to be here.
Along with Natalie, we have awesome guests. Today we have Miss Marquise Alston Allison, Executive Director of First Ladies Health Initiative. Welcome.
Thank you for having me, Mike.
Hi, everyone. My name is Marquise Alston Allison. I'm originally from Chicago, living in Los Angeles, and I'm the co-executive director of the First Ladies Health Initiative, a national nonprofit that's been focused on health equity for over 16 years. We work through trusted churches, community spaces, and digital platforms to bring life-saving health information and resources directly to families, especially Black and Latino families. Right now, I'm proud to be leading our maternal health work, helping to raise awareness around postpartum care, blood pressure monitoring, and closing maternal health gap for healthy outcomes. You can learn more at thefirstLadiesHealth.com.
We also have Dr. Robin Drake, obstetrician gynecologist at Rush University Medical. Welcome.
Thanks so much for having me.
Hello, I'm Dr. Robin Drake. I'm an obstetrician gynecologist. I work at Rush University Medical Center. As an OBGYN, I take care of girls and women from adolescence through after menopause and those that are assigned female at birth as well. And happy to be here for sure. I'm originally from Washington, D.C. area and have been in Chicagoland for about 21 years now. You can find me on doctors.rush.edu.
And last but not least, we have Minister Ray Roger, the pro-humanist minister. We're happy to have you here today.
Thank you. Happy to be here. Hi, I am Minister X-Ray Roger Bird. I go by they, them pronouns. I am from the southeast side of Chicago by way of South Shore. I am America's only and first openly non-binary minister, pro-humanist, and first 21st century community builder. I am the founder of Divine Godmother Ministries and a minister of anti-domestic violence abuse. I am a devoted child and CEO of Pro-Humanist Church of Godmother Nature.
Yes, and we have some amazing things to talk about and some not so amazing things to talk about today, but we're going to hop right into it with our topic, which is policy change, advocacy, and health literacy.
We got to get into the topic a little bit more. Policy and advocacy, especially in healthcare. What does that mean to you all?
I think starting with policy, we're talking about kind of the external forces that are really at the head of our systems. The laws that healthcare systems, individuals have to abide by. And a lot of that is stemmed from our lawmakers, which we have, some influence over and don't have a lot of influence over at the same time. And then advocacy is how we can, do things for ourselves, really, how we can speak up for what we need, what we want. And a lot of that is based in community organizations, community groups. But there is some overlap between advocacy and policy in that advocacy groups can really help change policy. They can work with lawmakers. They could do things like lobby at the local and regional and state level, national levels to influence policy.
Great, thank you for that, Robin.
And don't forget health literacy, too. I don't know if you want to speak to that one. We talked a little bit about policy and advocacy, but how do you see health literacy fitting into that dynamic?
Yeah, I think that's really important thing to think about. More from a individual and community level. There's just a lot of differences in how we talk to each other between organizations, families, communities, and law and hospitals. And we're not all speaking the same language, and definitely speaking different languages between policy and the actual healthcare that people need. From the individual standpoint, some of it is just, do you understand what people are talking to you about? When you get instructions, can you interpret that in a way that you can actually use when you get home? Do you know how to take your medications? Do you know where you're supposed to be or the next step that you're supposed to do? And then when you have questions, are you able to communicate back to someone? Are you able to use technology in the right way? Like a lot of systems are moving to, the mic chart and digitalize everything. And some people just don't have access to that, or they don't know how to access it. And so that creates some barriers for how literate you can be about your own health.
There's even kind of like de facto kind of behaviors, like what's just accepted as true, what's just accepted as the way things are, but we don't necessarily think about or scrutinize if it's the way things have to be. Mm-hmm. And of course, we talked about health literacy as well. And I mean, even sitting here wondering, when's the first time I ever learned about what my rights are as a patient or how policy influences that? I was certainly an adult. I was probably married. I probably already had children. And, there came to be a time in my life where I realized that that there was space for movement and advocacy, and there's space for my autonomy and my decision making within these within healthcare systems. Because growing up, it was very much like, do whatever you're told, that kind of things. It sets up a power dynamic where you're kind of afraid. It's like my life is in their hands. I got to do what I'm told, and that can make a vulnerable group of people even more vulnerable. Absolutely. So that's what I wonder from you all too. Is like, what do you know about patients' rights and birthing rights, and where did you learn it?
Very good question.
I was looking into maternity rates as a student in seminary. It was an assignment. We had to have a finals and pick a topic dealing with racism in America from a faith standpoint. So I took my newly found religion at the time from birth, which was self-genesis, and I used from a spiritual lens at the maternity rate in America, and saw a pattern of abuse, neglect, and mistreatment that was clearly a pattern that can be recognized from lived experiences, from testimonies, and clearly from the data itself, the raw data. I was truly alarmed. This was in between February to June of 2022 when I found this information out. I was in a group project.
And how old were you around this time?
So 3 years ago, 36. Okay. So now I'm 39. So in that time, I didn't know that the maternity rate amongst Black American women were so high. When I heard about the maternity rate, I usually heard it from a standpoint generalized. American women, maternity rate.
And you referred to the maternal mortality rate.
Yes, the mortality rate, thank you. Mm-hmm. And what that discovery showed me was we have an elephant in the room that's being ignored. And unless you're a woman identified, or you have some, as they say, skin in the game, mm-hmm. then you really don't know, or you're not aware of this issue. Mm-hmm. And so a lot of people are focused on sex in the bedroom. But after the bedroom, there's birth, there's experience, there's life, there's a ritual that existed prior to any kind of colonization or healthcare system. Mm-hmm. And it's being ignored. And so I was alarmed, I was offended. So I said, okay, let's make our project, our group project, center around the Black maternity rates based on our different religion and spiritual lenses, called intersectionality. So you're using the lenses from your faith, and you're saying this is how we're going to address the issue from that lens. And it was supposed to be a hypothetical challenge. Did you know a group of, let's say, 7 people, majority women and majority white women, 2 Black women, I'm the only non-binary, and majority white women. Do you know that they were up in arms about us focusing or refocusing our topic on Black women and dealing with the maternity rates? And it was shocking because these are women that say, I'm a pastor of this faith. I'm from this religious sect, mostly Christian. And yet they have this facade, I got all of these titles, or I'm gay, or I'm lesbian, I'm have all of these labels of their sexuality. But when it came to addressing actual issues and using their religion not to weaponize, but to galvanize, to empower, to address the issues of the people, it was silence. Actually, it was fight, it was resistance.
Wow.
And so I realized that, okay, so we're not on the same side. We're not celebrating the same God. We clearly at odds with each other. So they changed the focus of the topic. I was outnumbered, only non-binary person there. And so they changed the focus on the healthcare center and how people can have the experience, but from their lens without talking about the elephant in the room.
Sounds like they could not see themselves in in the black birthing person. It sounds like they could not see themselves.
And so they didn't find it important enough.
Yeah.
No, it's very interesting. I read that reminds me of when I interned for the amazing Congressman Danny K. Davis, and at the time that I was interning, he was working on a bill called Education Begins at Home Act. And it was a bill centered around educating people who were new mothers, new families, mom and dad too. And the pushback I watched him get on the congressional floor was crazy, but it was a bill towards black and brown people. And I just, I was still in college. I couldn't believe my eyes. It was just like, well, wait a minute, 1 + 1 = 2 to me. What's happening here? But it's the same thing when you're not being directly benefited from it from other cultures. It's like, oh, well, that can't exist because it doesn't benefit me. And I completely understand I experienced something similar, and I thought that was eye-opening.
In part, that touches on the experience of being black in the USA, I think.
And specifically, when we're talking about the healthcare industry and going through the health system, when literally there's documented evidence of them thinking we had higher pain tolerances. And some of them asking doctors today, present day, and they still believe that to this day. Like all the biases that exist in the healthcare industry that we have to fight against, whether we know we're fighting against it or not.
And how those biases have made their way into our psyche where we believe it. We believe that we are immune to pain or that we're more resistant to pain, even if not just like, our nerve endings and all that sort of stuff, but emotionally and what we can take and what we can weather and all of those sort of things. And
though we are resilient pain
always
still exists emotionally, physically, mentally. That pain still exists, and we have to address it. And so I think that's where the advocacy comes in, because someone has to say, hey, we need help, and it's okay. Now, how do we get the help that we need? And then show them, because a lot of times we talked about the healthcare and not having maybe access to it and bringing it in spaces where people are already congregating. That's amazing. But then how do we do that same thing with mental health services, right? There's so many people that need therapy, and then the biases against therapy, particularly in the black and brown communities, right? As we're fighting against that, and more people now, I feel like more than ever, are like, I'm in therapy. Or I need therapy, or I'm about to go to therapy. That's a beautiful thing, but how do we get them access? Because the same amount of people that's like, oh, I need therapy now, I realize that I want to go, don't have the insurance to cover it, don't have the access, can't find a therapist that fits them, because that's a whole nother thing when we're talking about advocacy in healthcare. How do you find a therapist that understands you as a melanated person, the struggles, the generational traumas, and all the other things? All of that plays a role in it, and we need those advocates in that field, I feel, just as much as physical health as well.
Yeah, I think right now in our Congress, we have an amazing thing happening where we have the Black Maternal Health Caucus that is led by our own Illinois Rep. Lauren Underwood. Also, that's helped championing with her is Commissioner Donna Miller, that is a local Southside commissioner, and also Congresswoman, sorry, I'm blanking on her name.
Robin L. Kelly.
Kelly. And it's really all from Illinois, and it's really profound to see all of the work that's being done, and they're going beyond insurance companies, they're going beyond that stuff. I know one of the works that we did last year was PTSD caused by racial trauma. Police brutality was one of our topics, domestic violence, things like that. What we learned in our research was that people didn't know how to label what they had. They didn't know what anxiety looks like. Depression looks like anger for Black men, and that can be something that is just misdiagnosed or get you put in jail, right?
Exactly.
It's one of those things. And so we did that research through PCORI, PCORI, which stands for Patient-Centered Outcomes Research Institute, which led us into what we're doing now, which is in our Black maternal health, and that's also funded by PCORI. And so we're rolling in what we learned from our PTSD into our maternal health. Our grant is specifically focused on women that are pre-postpartum, excuse me if I'm getting this language wrong, and post have just had babies and their blood pressure. What we're finding is that if we can do some at-home monitoring, and because you have that stigma of going to the doctor and feeling like you're less than, or just the systematic things that have happened in our healthcare system throughout our time here in the U.S. Has hindered it. So what we're trying to do is use that research, which says that if you have blood pressure and monitoring, that really helps with the death rate that's happening in Black mortality. So we're trying to penetrate that. We're also trying to figure out how do we get these home blood pressure monitors into the homes of people. And we've been working with the Preeclampsia Foundation and Family First, which does nurse in-home visits. And I think those are the next steps. So that's the world of maternal health is now. How can we make this stuff at home so you don't have to leave your baby, you don't have to leave your space that you've made, and get the help that you need.
Oh, I love that so much.
So much.
And it makes me think of something that Robin was kind of talking about with like how people can access care, and then you're talking about how people can access care. I was going to bring up that one of the resources I often refer people to are care coordinators through their insurance company. Whether you have a paid insurance company, if you have Medicaid insurance, there are usually a care coordinator that can help with things like that. And then I was also going to bring up about house calls. That's one thing that I really love about naturopathy or the naturopathic profession is that not all, probably not even most, but some naturopathic doctors, they still make house calls. There's that old skill of the art, really. I would say it's the art of the house call. And there's a lot of things that go into entering someone's space, but there's so much that you can learn about their health and their well-being and where they are and what treatment modalities will work best for them and what they might be resistant to and all those sort of things. So just to hear what you're saying, echoing that, yes. And I know Rush has an initiative, where they're seeing people postpartum to do that. So I love hearing things like that. I mean, there's other community-based practices like community-based doulas, or doulas, period, or home visitors and things like that. But I do think, when I think of the future of advocacy and health literacy and things like that, I do think it's bringing healthcare more locally and even in the home.
I love it.
And making sure that people have the means to pay for it or cover it. I think that's one of the biggest barriers to all of it is we can have these systems in play, but if we lose our expansion of Medicaid, per se, unless people are covered or people are underinsured, they just don't have the access to get to these things.
Yeah.
What Maya was mentioning too is the Family Connects program, so they're Chicago-wide. So at Rush currently we're one of the pilot locations. So every delivering patient at Rush that lives in a Chicago zip code can get a home visit around 3 weeks after birth. So the nurse comes in, does a 2 to 3 hour session with the family, kind of see what their environment is to talk about breastfeeding, safe sleep, any resources that they're missing that they need. And so it looks at it from a little bit more holistic standpoint. And then they're able to, at least through Rush, contact their provider that saw them too and say, Susie's struggling with depressive symptoms now. These are the resources I gave her. Can you reach out? Can we get her an appointment soon? She's having lactation issues. Can we, prescribe medication if it's relevant, things like that. So it's another
point where the patient doesn't have to necessarily advocate for themselves, but they have someone there to speak for them.
Let me bring policy into this right quick. So you have to remind me, because I have, I gave birth to our little ones with midwives. And one of the reasons why is because I wanted to be home as soon as possible, and I didn't want to have to go back out a lot. I remember supporting moms that maybe gave birth in the winter time or whatever, and postpartum, they are told that, I think you remind me if it's a 2-day visit postpartum or a 2-week visit postpartum, where they have to come back to the clinic.
Yeah, so for the birthing patient, it's usually 2 weeks if they don't have complications, but if someone has complications, high blood pressure, you usually see them earlier. So things like that you're talking about, the home blood pressure cuffs, those can be really helpful too, so that patients can take their own blood pressure if they reliably know how to do that and have access to a cuff, which is a big barrier we're finding out, just getting access to that blood pressure cuff, that then they can communicate without having to leave the home. But also, the baby takes them out of the home a lot, so we don't talk a lot about the pediatric needs that baby needs. So sometimes they're sent home, but they have jaundice or they are having weight gain issues, and so they're actually seeing the pediatrician the most during that first week. So pediatricians now are taking some responsibility for maternal mental health as well, and doing the screenings, like the Edinburgh perinatal depression screening, in their offices. So I have people come in and they're like, I've taken this 3 times with the pediatrician. My mood is okay. But that's another access point for them, because they're seeing that pediatrician during that week for babies. So we usually only see them at 2 weeks.
And I asked because I'm wondering if that initiative that you were talking about, if that could take the place of that, that first visit, either for baby or for mom. I would imagine, or for the birthing person, I would imagine that if there are complications, if they are checking for jaundice or something, that, they're going to want an in-office visit. But anyway, even if that's not the policy now, I would love to see it go in that direction. And like I said, that is one of the reasons why we chose midwifery, so that we could get that care right in home. And earlier I was talking about where we learned those sort of things. I'll say that when I was in naturopathic medical school, that's where I learned, as far as policy and things like that, I learned those things, but from a liability standpoint. I remember my supervisor was always like, okay, every chart has to end with ICO, informed consent obtained. You had to have that on every page, all that sort of thing, but it was from a liability standpoint. Then as a birth worker doula, I started learning more about policy and law and things from a patient's rights standpoint. And even me now, I still worry, I don't know it all, or you're going to get tripped up, or you're going to have to, you got to pick your battles and all that sort of stuff. But one of the things that circulate a lot in our community is this fact, and it's that hospital policy is not law. And that's, one way to think about how you do advocate for yourself, and how you prioritize what options you do have.
And then that just brings up the point, after you have the baby, and this is a huge talking point, I feel like now more than I've ever heard it before, with the cutting of the umbilical cord and then your sac, right? So after you have the baby, they take it immediately, and they you can't have access to it anymore, right?
We've changed all those things. No.
Right? And then so now it's no. People are like, no, I'm going to take that with me. And now they're saying you can get so much money for it and different things like that, and the hospital sells it and get that amount of money for it. And so now people are like, no, I want that and my baby. Thank you so much. And where some people said that the hospital said, no, you can't have this, literally telling them no, they will not give it to them and they cannot take it with them. It is law. When you said the hospital policy is not law, it may be hospital policy, but legally, that came out of me.
Yeah, it's your own organ, and you can have a lot of stressors with. I remember being like, if I get a tooth pull, it's I want my tooth. That's my body part. I want that, and sometimes they will fight you on that, and you got to see if it's important to you have to fight yourself. As far as I know, if placentas are maintained at a hospital, they're supposed to be incinerated. I know that in the community there's a lot of conversation about, are they incinerated, are they being stolen, are there still seals, this and that. And I think because we have that history of mistrust within medical systems, and we don't have the responsibility and the onus from the healthcare system as a whole of being restorative and healing those relationships, of course we're wondering. We've been experimented on so many times. To this day, I'm sure some people will wonder, did they take that? Are they experimenting on those cells? Did they get money for it that I could have gotten, and all those sort of things. I know when it was supporting families in Toronto, there was a lot of talk about stem cell banking, cord blood banking, but it was so expensive. You know, $1,600, $2,000, and things like that. So just being able, and like what you were saying, Natalie, like that's another policy thing. The pushback that I would get, when I was supporting someone else, it would be like, you can't have your placenta because we don't have any place to store it. Okay, well, I'll bring my own cooler and we'll make sure that it leaves the premises at this amount of time. And sometimes they'd be agreeable, and sometimes there would be like a lot of resistance there. And that leads into conversations about testing your blood and having consent to test your blood, and all those sort of things. But those are policy and advocacy things that go into birth planning, go into being a patient. But you don't know what you don't know, right. And we don't have our providers necessarily being like, well, you could do this or that or this or that. And I feel like we need more of that.
Absolutely.
Yeah. And I think it's important to know what your rights are. And also, if you are delivering within a hospital center, like what their policies are, and like you said, they're not laws. I want to make sure there's not misinformation out there. No one wants to sell your placenta. It's an organ. We're getting rid of it.
Is it incinerated?
I don't know if it's incinerated. I'm trying pathology, but yes, there's nothing that we can use from a legal standpoint either that is part of your body unless you've signed consent for us to use it for research. But it is your right if you wanted to take your placenta home, it is. I'd say that times that from like a medical standpoint, we don't advise it is if there's an infection during your labor, because that could potentially cause an infection for your baby down the road. Or if you also have group B streptococcus, so we do a swab at the end of your pregnancy to see if there's group B strep or group B streptococcus in the vagina or rectum. And we know that group B strep can cause infections for a baby, especially in their immune system when their newborn is not very strong. So there have been cases of people that have encapsulated or turned their placenta into little capsules with group B strep and transferred it to the baby where they've had baby losses. So some of it is like legal, like we don't want to send you home and say it's okay to take your placenta if there's going to be an infection. Outside of that, most places are perfectly fine with you taking your placenta, doing what you want with it.
I'll interject there too. Another concern I remember in the news some years back, someone took their placenta and they buried it, which is really quite fine.
Right.
They didn't bury it deep enough.
Oh no.
And they buried it, I think, in a public park, and like a wild animal got a hold of it. So there's another, just a cautionary tale. I am a proponent, and I will say, each one of the placentas that I had, we kept it, and we did bury it in a responsible way in the place that our child was born. So that was kind of what we wanted to do. But the cautionary tale there too, because you got to do it right. You don't want the strays to get at it.
Do your research, right?
For myself, for my second daughter, my second daughter was born in the hospital, but her mom had a midwife, a doula. And the policy, she had a birthing plan, and we looked at the policy of the hospital. She wanted to keep her placenta, and she did not want an epidural. She wanted an all natural birth, and I'm proud of her to say she did. And I am thankful for that. But the experience, unfortunately, was traumatizing because of the piss poor bedside manner, which nobody talks about. The arrogance of doctors when they know they have the power dynamic advantage. So you can know policy, but if their procedure is we're gonna give you your child this shot and there's nothing you can do about it, to me that's non-consensual procedure, and that's a form of medical rape. And so what I've learned from my experience is that, yeah, you can know the policy, but if they ignore birthing plans like they ignored ours and forced a K shot on our child a day before Father's Day and had a white doctor arrogantly act like there was nothing we can do and force that our child to have that shot was the most traumatizing thing ever. And to be helpless and not have no parameters to hold them accountable. And then to find out that these hospitals are working with DCFS to report you if you live a native way and live according to your birthing chart and live according to your religious and spiritual practice, and undermine you and report you to DCFS who puts a charge on you, an investigation, and to justify either taking your child from you or justifying why they're charging you for medical neglect, which is a hustle word for white people want to take your kids. And so when we're going to white-centric spaces called white hospitals that are ran by majority white people in power structures of a white-centric anti-humanistic system that uses subhuman capitalism to validate or invalidate our lived experiences, to me, policy is not enough. We have to go to language. So the art of language is, to me, the true art of war.
That's that literacy.
Thank you. So health literacy is knowing the words and the legalese that will protect you or put you in harm's way. Unfortunately, we have been programmed to celebrate the same God by just using it, but I need everybody to know here, as someone who has straight A student from the University of Chicago Seminary, God is a title just like Mr. and Mrs. So put something beyond God. What God are you serving? Are you God of anti-humanism or God of pro-humanism? Hence why we created Pro-Humanism Church of God Mother Nature, so that it's in the language that we are what we say, Pro-Humanism Church, rooted in God Mother Nature. Nature natures, nurtures. And if nature is not being nurtured, it's being undermined. It's being promoted as anti-humanism, and that's the healthcare system we have. If we didn't have anti-humanism, there would be no maternity fatalities, there would be no abuse or harming of Native women, and Native women would be freely to be who they want to during their birthing experience. And to me, America should have the most dynamic birthing centers in the world, giving the financial status we prompt ourselves on. So that shows you that capitalism and economy has nothing to do with the birthing experience or lived experience of Black women that deserve the same rights and respect of white women. And until we have that, then we have a duality system, a system with two tiers, where if you're a white-centric with money, you can be respected. But if you're not a white-centric, or if you don't have money, you're not going to be respected. So first, we got to talk about healthcare and make sure that the care in healthcare has respect in it. Because what's healthcare without respect? It's a waste of time, and it honestly is promoting violence.
An expensive waste of time. I was watching the news the other day, and it was saying that, like, for health outcomes, the U.S. is something like 69th globally, but our insurance and the amount of money that we pay is by far number one. That number actually really kind of threw me, and I hate to say that this is the truth, but my experience have caused me to believe oftentimes that a lack of health literacy in our communities and among patients can benefit the health system. There's a lot of kind of autopilot. I mentioned this before, so not to be a broken record, but it can be very hard to be seen and treated as an individual and as someone that has, kind of a life outside of this interaction, and how the healthcare and the treatments that you get affect your community, your household, and all those sort of things. But it's, very cyclical. It's very cyclical. So I think that the weathering and the bad and the trauma, like you described a lot of trauma and pain, that those are the things that we have to heal from, but in healthcare, it is first do no harm. So I would like our healthcare, I'd like to see our healthcare systems and our policy and our advocacy and literacy move to a place where we are not recovering from it, we're not recovering from it. And with literacy, language is very important. So I did want to say just a couple things from what I heard. So midwife and doula, those are two different things. Doulas are non-medical professionals. We are skilled, we are, and now in Illinois, Medicaid reimbursable, but we are non-medical professionals. We're really emotional, informational, educational support, contraction support. Whereas midwives, like obstetricians or MDs or DOs that deliver, they are medical professionals that, catch or receive little ones.
I look at doula care as your lawyer in the birth room. It's literally what you need, because you're signing away whatever. You don't know what you're signing. You're in if it's your first birth, it's the most important time of your life. It's so important, but unfortunately, it's been the people who need doula care, which I think is all birthing persons. The stigma around it makes people shun it. There has to be more advocacy work around dispelling the myths of what a doula and a midwifery is, because people look at it as if it's, you know, hoodoo or voodoo, or is a witch doctor coming to your house, but really they are the lawyers in the room almost, advocating on your behalf, and they create this whole plan. But even with doulas, I know you are a naturopathic doctor. I right now have a girlfriend that is studying to be a doula, and she's so limited in the U.S. that she's in Brazil, because they have the best doula program in the world. Wow. And she can't get the same training here that she can get there, and so it's very interesting. I know Illinois, we just had the bill come down. I know that there was $1 million grant that came down specifically for doula and midwifery services now that it's being added in. Same thing in New York. I think that just came down a couple of years ago. But what we are also seeing is there are not a lot of birthing centers, despite all of these changes. They're treated completely separate from hospitals. It's almost like you have to choose the independent birthing center versus the hospital. It's like, why? How come we can't merge? Why do all these birthing patients have to give birth on their backs, when knowing that that's not necessarily natural, or it's not necessarily comfortable for every patient. So I think it's in my mind, all I'm thinking is doula.
Get you a doula.
I heard doula. One of the things is a lack of standardization among providers.
Yeah.
You might get yourself with a Dr. Robin Drake, okay, and you might be set up and have a culturally reflective care, someone who listens to you and has been in your shoes, or you might get, someone else, Dr. Jane Doe, and they're like, nope, you can't do that, nope, you can't do this. So I would like to see more standardization, and not to the lowest denominator. We needed to bring it up to the highest denominator. I was just thinking about supporting a mom. It was the first mom that I had ever supported where she ended up giving birth in what we called the elephant position, or on her hands and knees. And I was so proud of just the situation that she knew that was what was best, and the folks around her supported her in that decision. I've also worked with someone who, in the morning shift, everyone's great, and your birth plan, and we'll talk to you about it. And at the night shift, she had a nurse come in and say, you know what, the best place for this birth plan is in the trash, because nobody's to listen to it. Yeah, that hurt when the mom told me this. I can see her and imagine it right now, because and this was also a mom who ended up getting an epidural that was really forced on her. She was medically coerced into getting it. And just imagine me, and this was during COVID, so I was on the phone with her. I was not able to be there in person with her. And after, when we're processing her birth story and stuff, she was just like, Doula Mai, I felt like I was sold a lottery ticket that just didn't go anywhere. That was just the worst lottery ticket ever, because she was coerced in that way.
I definitely feel like having that advocate is important. So definitely doulas, definitely midwives, people that can guide you and support. But if you, for some reason, can't afford or don't have access to, I think making sure that you communicate and create people that can be your advocate within your partners and your family and the people that you choose to be around you in that space. So like if you have a partner that's going to be with you, if your mom is there with you, if your dad, your best friend, your aunt, whomever, your sisters or brothers, whoever is going to be there has to know the plan, and they have to be the one, even when you're just exhausted and cannot, they're the ones that's like, no, this is what we said we were going to do. But also, again, choice. If you decide to change your mind, it's not because they said it, is this what you want? Type of feedback and advocacy in that moment, because you can be in a situation, as too many people have been forced in situations where they just did not have anyone to stand up for them, and they just didn't have anything left, because it's exhausting physically, mentally, and emotionally to birth a human. It just really is. And so I think it's important to create those advocacies, but if you can, absolutely do for sure. So as we get ready to close out and circle out, thank you for all of your opinions and your feedback. I just want to give some last closing remarks, if we could just go around for everyone. What needs to change, and how can we change it in relations to the policies that exist, and creating advocates in our communities, and encouraging people to stand in their power. One thing that I loved about what Mai just said was, no, you my doctor. Okay, this is what I want. Can you support me in this? If not, we need to find someone else. And doing that at the door. I'm here for boundaries. I'm here for setting up expectations at the door. So with that, what would be some things or some advice that you would give a listener or listeners that are interested in what we can do to change policy and creating a better future for policy and advocacy and literacy in our communities.
I think from my standpoint, and knowing that First Lady's Health is working on with the Corey funded project, from an individual level, reduce your stress. Any way that you can reduce your stress. It is the number one cause of most and all diseases, and it will, as much as you can, please just reduce your stress. I think we just need more training. It sounds like these look, there's pieces of it all here, but it's about bringing it together, and that requires more conversation, which we're doing here, and that requires more advocacy work and more boots on the ground as it relates to our policymakers. I think that's huge. But yes, reduce your stress. I do want to hit on one little topic that revolves around my preeclampsia, post-eclampsia research. Is my mother is doing a study called START study at Rush University Hospital, and she has Alzheimer's. And so what they're doing is they're testing blood pressure, different mechanisms that reduce the blood pressure. And she's in a study where the Chicago Symphony Orchestra, a violinist, comes to her home and plays a violin for her for 30 minutes. They took blood pressure when she first started. It was at 124/60. When she got done, they did it again. It dropped 20 points. The power of music, the power of just a calm space really helps people, and really, I think, will be really beneficial to birthing patients in this time and age. So my message is reduce your stress, keep your blood pressure low.
Awesome. And then I don't want to lose the points of boots on the ground when it comes to the policymakers too. Yes. Keep the fire to your policymakers. They exist, but I also don't want to discount the work that they're doing. They are bringing funding down. They are doing the things that they need to do. We have more women in office than ever before, and they're fighting. They're fighting for maternal health, whether they're black, white, brown, pink. Everybody knows that maternal health is these women have gone through it, so it's so important. So yeah. Talk to your congresswoman. Talk to your commissioner, your alderman or alderwoman. They are there, and they have resources.
Now, I wanted to bring up one thing since we are talking about policy for sure. One thing that's really impacted maternal health, and that was the Dobbs decision from Supreme Court, so striking down Roe v. Wade, and how abortion access has really limited reproductive rights and justice, especially for Black and brown women, low-income communities. We are very lucky in Illinois to have great advocates, great policies. I have patients that are just over the line in Indiana. One went to the ER, had a much different experience when she went to the ER in Indiana than she did when she crossed the border for her maternal care. And so just thinking about how we advocate for our family members, ourselves, our neighbors, and not everyone's going to be able to have 5 university hospitals. It might even be more than that in Chicagoland. They might have to drive an hour and a half to get reasonable care. So thinking about how that impacts our maternal outcomes throughout the U.S. And really have to fight for us to have better access, better reproductive justice, knowing that abortion care is health care and maternal care, and that impacts us for generations to come to have that loss.
Thank you, Evan.
Coming from the pro-humanist standpoint as a minister, pro-humanity and the history of anti-humanism needs to be explained, explored, and discussed. That we live in a system that was founded off exploitation of humans, specifically of women, and that the medical system was founded on exploiting and harming and creating trauma on Black women. So once we put that out there, we can stop playing around and get down to business. So I am coming from the standpoint that if you're gonna have a healthcare center and a system, it needs to be rooted in pro-humanity. So whatever pro-humanity means to you, we have our own explanation of that, but I challenge everyone to find out what pro-humanity means to you when you hear that term. And then explain to me, is this system reflective of pro-humanity, pro-humanism, or is it reflective of anti-humanistic process, principles, systems? I would say, and we declare through our religion, that is founded and rooted on white-centric anti-humanism. I'm gonna say it again, white-centric anti-humanism. And so as long as we have a system rooted on white-centric anti-humanism that is encouraged, I said encouraged, I'm gonna say it again, encouraged through capitalism, monetary support, monetary themed, then we have to understand that money is not the root of evil. It's the system that predicates and supports and encourages money to suppress, undermine, and neglect the lived experience of Native women, Native peoples, period. And so the policy needs to be where we can hold you accountable if you're doing your white-centric anti-humanism, period, on paper. I don't need to I don't need to try to figure out to prove that you're being racist. No, if your practices and principles and the results and outcomes specifically causes a trauma or causes a do harm, you are specifically in violation of pro-humanity and specifically an active anti-humanist. And we need to use terminology that puts people in their place.
And the oath that they took.
Period. And so that is what creates change. And then the advocacy of somebody like myself who can hold somebody accountable, because I am the founder of pro-humanism theology. And I started it 3 years ago. So anybody that tries to lie about what pro-humanism and pro-humanity is supposed to be, they'll be lying, because I am the founder. And I'm non-binary, so you can't say it's biased against women or biased against men or biased against children. I purposely came out non-binary to read out any gender discrimination, because I felt that as long as we have gender-specific policies, procedures, advocacy, we're not going to address this issue. So you have to have non-binary and men advocates to support women getting the support they need in a system that's not predicated for them, but predicated on white-centric anti-humanism and white-centric spaces based on elitism, money. And what's a white elitist? Based on monetary, then we need to wipe the board. So we want to advocate for policies that changes the board, makes everybody held accountable legally, where you can sue them. And then also be able to rate them on their bedside manner and give hospitals the credit score. Hospitals need to have mandatory credit scores.
I ain't mad at that at all.
Doctors need to have mandatory credit scores. And if you go below that credit score, you need to have insurance. So we can ensure you know what to do or you don't know what to do. And so that's why you have to be insured. And I'm telling you that would change the game. And then lastly, we created a church, a safe space for women who want to be doulas, midwives, to create this, co-create this church space with us. All I did was create the policies, procedures, and now I have the safe space. We're looking for those to come together and make this new reality of a pro-humanist centered birthing spa experience. And so that we challenge the white-centric status quo with true alternatives that are attractive. That's all in my
All right, that's great. That's amazing. I want to just say amen to everything you all said, and I should touch and agree. For me, I think we have to get informed, so that health literacy is very important, not just on understanding the language of health, but understanding what's actually going on. Right, we talking about like the mortality rates and talking about just the rate that we are dismissed and mistreated and wrongfully diagnosed and all of those things. Once we get informed and we actually see what the issues are, then we can go and push those elected officials to say, no, this is the actual problem, and posing viable solutions. This is what we can do instead, because we don't have to just tolerate what has always been. We can actively do something different. I believe in people power. I strongly believe in people power. So if we collectively come together, get a good understanding of what the issues are and pose viable solutions, and then put pressure on the institutions that exist and then the people that can actually change the policies, collectively, I feel like we can actually make a difference, because there's no reason why we ain't got free healthcare.
Yeah.
There's no reason why we ain't got free healthcare.
I know that's right.
Can I say one quick
Go
thing?
for it.
I think really it is getting people in the room that understand what's going on, for sure. I think one of the things with our policymakers is they don't have medical backgrounds, science backgrounds. They mostly are not women. They don't have, a birthing body, and they are legislating our bodies without any knowledge of what we're going through and what potential solutions are, and monetizing it too. So it's getting monetized from the top down. I would
That part.
I was like, well, there's a lot put on doctors. I'm just going to throw it out there that we can't control. Insurance companies won't let me prescribe things I want to prescribe for patients. There's limitations that we have on time we consume with patients to get our salaries paid. We also have things out external that we have to take care of in our own lives. Things like that are just not. The system it's broken is the easiest way to say it. But there's so many things, and it's a lot of monetizing something that should really be more of a right than a economic institution, which it is.
So right, you're so right. Chicago is home to the largest medical district in North America, of which Rush is a part of. We got Stroger over there. I know I'm not going to get them all. VNA is over there as well.
The VA is over there.
VA, sorry.
University
VA.
of Illinois Chicago is there.
Yes,
Yeah.
This is the largest medical district, and I think that's something that Chicagoans should be able to feel proud about. And I have also learned in my work as a birth worker that there is a hierarchy within the healthcare system. A lot of times we do say like, okay, hey, and we do need doctors and nurses and specialists to be our best advocates. We do need that, and we need more of that. But I have recognized there is that hierarchy. Robin just mentioned an insurance company. There's also the institution and the board of trustees and all those sort of things. But what I would say pro-humanist means, from what you said to me, is patient-centeredness. And you mentioned PCORI earlier. This is patient-centeredness, and I think birth tells us a lot about what it means to be human. And as far as like how we can access some more supports and resources, there is an app called the Earth app. It's Birth Without the Bias, right? And that is an app, IRTH app, that people are encouraged to go and put their experiences of hospitals or healthcare spaces in there, and it does generate some sort of feedback or a report card of some sort. Last time I checked, there wasn't as much of a presence, there wasn't as much data collected in Chicago as in some other areas, so we could do a better job there. Also, folks can check on, they should be able to get C-section rates of hospitals and providers, VBAC rates of hospitals and providers, but that information can be hard to find, and so we need more transparency there. I would also say, as far as what we need, workforce, like I said, boots on the ground, so I won't take too much time, but what I will say, folks are capitalizing on the money that's coming down. It's never enough. The money that's coming down for Black maternal health, for birth work and all that kind of stuff. And you have a lot of groups in Chicago that are now training people to be birth workers, training people to be doulas, training people to be patient advocacy patient advocates, for free or low cost. Get you some of that. Get those skills in your fingertips. Birth work is a craft. And I'll be the first person to tell you, a training does not a doula make. It is a craft, it is a skill. So, go out and engage with some of those things. And for the providers, know that, for health literacy, the information that you all share between your colleagues and stuff, that's not out of the realm and grasp of the people that you support. And patients know that is not outside of your realm. You can understand those things. You can, as long as you're privy to that information and those conversations. And I think we also need more intra-profession collaboration, less biomedical supremacy. We need the naturopaths to be able to speak to the MDs, to be able to speak to the DOs, to the Reiki practitioners, all of that, because that's what patient-centered care would necessitate.
And for everyone's opinion and voice to be respected.
Yes, and to be respected as colleagues, because that's one thing that I see. So in doula, we have a training, a doula training, and also patient advocacy training, and I let the doulas know, like, you are not inferior or superior to anyone else on that birthing person's team. Some of the things that are working or moving in the right direction are community-based supports, peer-to-peer supports, and also culturally reflective supports. So, yes, I thank you guys so much again for being here. What a robust conversation. And I hope you guys will come back and we can continue these conversations and more. I really do. So I'd like to keep that door open, and hopefully you guys will continue to engage with us. And for everybody listening in, I just want to say stay connected with us through our social media, our In Doula Community Alliance. newsletter. Also make use of the resources on our website, our reproductive sexual justice toolkit, our patient advocacy toolkit, and also our Legacy Wellness Warm Line, which is a non-emergent line for birthing people, but also non-birthing patients to discuss their experiences in healthcare, gain resources, have a listening ear, and build community. So thank you again to our guests, but also our supporters and our sponsors. Thank you, Marquise. Thank you, Robin. Thank you, Ray. Thank you, Natalie. And thank you guys for listening in. Please check out the next episode and subscribe.
Yay!
All right.